MEMUP is our recently launched product. MEMUP capsules contain a combination of natural progesterone 100 mg and 1 mg of estradiol as hemihydrate. Jagsonpal Pharma brings you this US FDA and DCGI approved combination of bioidentical estradiol and bioidentical progesterone in a single capsule for the first time in India as MHT. Lycorid M tablets of natural lycopene fortified with N-acetylcysteine enriched with CoQ10 and L-carnitine. For added advantage, to win the race, Lycorid M contains two proprietary complexes, natural lycopene as lycobeads from Israel and L-carnitine and L-tartaric acid in ratio of 2:1 to give the highest available L-carnitine as Carnipure, which is sourced from Switzerland. A warm and hearty welcome to all the esteemed faculty and attendees. Please note this webinar is also streaming live on Facebook. The link has been shared in the chat box. To refer to this webinar again, please visit our YouTube channel, Jagsonpal Medical Insights. We have with us Dr. Jyoti Malik, Chairperson, Haryana Chapter of ISAR. Dr. Jyoti Malik is Director, Roots IVF at JJ Institute of Medical Services Sciences at Bahadurgarh. She will be initiating the program, and the MOCs for today are Dr. Manju Dagar. She is the Clinical Secretary of Haryana Chapter of ISAR, and the Treasurer of Haryana Chapter ISAR, Dr. Lakshmi Goel. So welcome to everyone. Over to you, Dr. Jyoti ma'am.
Yeah, thank you so much. Thank you and welcome each one on this platform. We are meeting on this new year for the first time, and I wish you all a very, very blessed and a very happy and healthy new year from ISAR Haryana. And with our motto of Prayas Evam Vistar, we are constantly making efforts and we are progressing. And this is our 11th Inspire and Ignite series. And we have today Dr. Amit Patki, sir, as the chief guest. Can you please rename, sir? Deepika, sir has joined.
I'll just do that.
Please rename, sir. Yeah, it is some other name, but he is logged in from the common faculty link. And today we have our chief guest, Dr. Amit Patki, sir, who is the Medical Director, Fertility Associates, Mumbai. He is Honorary Professor KG Somaya Medical College, and he is also consultant to Khar Hinduja Surya Hospital, Khar, Mumbai. Sir has 35 publications in national, international journals, 50 book chapters, and he is secretary and of MSR. He has been the chair of the West Zone, and presently he is the national president of our ISAR. And this actually is, he has been a constant support to our ongoing ISAR Haryana chapter, and with his constant guidance, support, and with our also support from our national secretary, Dr. Asha Baxi ma'am, we really feel blessed and we feel delighted to have you on this platform. So, Dr. Amit Patki, sir, we have a newsletter which you know by the name of Fertility Quotient. And this today is the 4th series that we wish you to officially release on this platform. So we would take your blessings, and we would also like you to officially release the newsletter. I'll just play that PPT so that you can have a look, and then maybe I will invite you for your words of wisdom and blessings. So I will just share that. Is it coming? One sec. Yeah.
Yes.
Yeah. So this is the fertility quotient, and this is actually just based on PCOS. This is our issue 4. In 2024, we had 3 such issues, and this is our first author for this on the international evidence-based guidelines by Dr. Meenu Handa, our clinical secretary, our general secretary. And then we have Dr. Manju Khurana, who has been the past president of ISAR Haryana on writing on PCOS pathophysiology. We have Dr. Jyoti Gupta from Gurugram writing on biochemical and ultrasound features of PCOS. Then we have Dr. Ishika Nayan from Hisar writing on diagnostic dilemma and management in adolescents. We have Dr. Meenakshi Mehta writing on ovulation induction for women with PCOS, and Dr. Pooja Bhayana on preventing ovarian hyperstimulation syndrome. Dr. Rakhi Malhotra, the past secretary of ISAR Haryana Lifestyle Factors. Dr. Priyakshi on a comprehensive overview of health consequences of PCOS. And I have put in a word on laparoscopic ovarian drilling in PCOS. And these are the glimpses of what the CMEs, the physical CMEs that happened at in 2024 on from this chapter. Though we are a small chapter, but we have tried to do a lot of put in a lot of efforts with our teamwork, with my secretary Dr. Meenu, and my clinical secretary Dr. Manju, and treasurer Dr. Lakshmi Goyal. So, and we have our vice presidents Dr. Rakhi and Dr. Anupma. Also, we have been taking blessings of our seniors. Dr. Maninder Ahuja is here. She was our founder. She was the president of Haryana chapter. From her, I've learned a lot, and I thank her for all that. We have this CME at Gurugram that we had. Then we had this hysteroscopy hands-on workshop at Rohtak that was organized with the PGIMS Rohtak, the apex body of Haryana, under guidance of Dr. Pushpa. Then we had this conference again at Faridabad organized by Dr. Lakshmi. Then we had, these are the glimpses of the same. Then we have this CME organized by a small, very small chapter from Panipat, but it was a very beautiful effort done by the Panipat Obs Gynae Society. Then we have the CME that was again organized at Amrita Hospital, the biggest hospital, I think, of Asia. And this was at Faridabad that was organized. Then we had you witnessed history, again being 3 chapters organizing this embryology national conference. The principal chapter being the Chandigarh, and then we were the associate chapters, Punjab and Haryana. And then we had the last CME of the year at Faridabad again on 19th of December. So this is all about the newsletter. It is just the glimpses. I've just taken one page of each so that we could at least show you that this is just a book, what this newsletter was. Now I request Dr. Amit sir to please say a few words and to bless us on this new year, sir. Dr. Amit sir. Sir, please unmute yourself.
A very good afternoon to you, and thank you very much for having me in this wonderful Ignite series. I've always complimented Haryana chapter for the enthusiasm that they have always shown through the year in their scientific endeavors, be it physical meetings, be it webinars, or even release of newsletters. Dr. Malik, I'm really envious of you because you have such an excellent team at your state level, and you all always are perhaps the first one. I think you did the first meeting when the year started, and I think you are one of those who have been regularly having your webinars and newsletters. I've also listened to your Ignite series, and I'm very happy that you choose the relevant topics, and more important, the right speakers for that topic. So you have a in detailed discussion on that topic, and I must congratulate you and your team for this fantastic efforts that you put in every month through the year. So I wish you the very best in the future, and I'm sure your Ignite series will go a long way in helping not only our junior colleagues but all practicing fertility specialists to update and reinvent their knowledge in treating the patient. So thank you very much once again for having me, and I congratulate you on your newsletter. Thank you.
Thank you so much, sir. And now I invite Dr. Meenu to please thank Dr. Amit and invite Dr. Asha Baxi ma'am.
Thank you so much, sir, for your enlightening words. It's always so encouraging that you join us for these series and keep encouraging us to do this work. Thank you so much, sir, for taking out time for us today.
Thank you.
Thank you, sir. We now like to move on with our the first talk. And could I have Asha ma'am CV, please? Dr. Asha Baxi ma'am needs no introduction. She's such a vibrant personality and a very lovable personality as well. Ma'am is our hospital.
Ma'am, internet issue.
Yeah, yes, there's some issue. So maybe I think we are losing contact with Dr. Meenu. So I would, it is now my honor to introduce Dr. Asha Baxi ma'am, my very, very favorite person, very humble, very helpful and very pleasant. Is the Secretary General National ISAR. She's lead consultant Asha Baxi Fertility Center. She has been Vice President 2022 West Zone Foxy, Joint Secretary of ISAR 2021, founder chapter of the MP IAE and ISAR, Chairperson Foxy for Infertility Committee, and to her goes the credit of giving the first ICSI, Tessa ICSI and Micro Tessa ICSI baby of MP. She has received Kumud Damaskar Award Foxy 2008-9 and the best paper in the Foxy Journal in 11 and 12. She has organized many conferences and she is also the organizing chairperson of AICOG 2021 in Indore. So before that, I would also like to introduce my chairpersons for this session. We have none other than Dr. Maninder Rahuja, a person who I think everybody in Haryana knows. She has been a role model for actually many of us. And today we are honored to have you, ma'am, on this this platform. This is our first webinar, and we feel good to have you here because you are the youngest of us all. Then we have Dr. Gurneesh. Dr. Gurneesh, sir, is the president of the Hisar Obsgynae Society, and he has been also a very helpful and a very I think a pillar of Haryana ISAR. You are that whenever we call you, sir, you are there, and the CME that you helped organize at Hisar with Dr. Manju and Dr. Bishnoi was a wonderful, wonderful conference where we could even get HMC points, and it was a 2-day event. Then we also have the two chairpersons, Dr. Poonam Lumba, founder of this chapter, and Dr. Manju Khurana. Though Dr. Manju is in Dubai, I think she might not be able to join. So over to, I think ma'am has already been introduced. So we would take the comments from the chairpersons at the end of the talk. And thank you so much, Dr. Asha Baxi ma'am, for taking though this on this very platform, again, I would like to everybody to just share this, though we have started with the new year, but still there are many things which I think which are not in our control, and it is all the destiny and God's decision that we always have to follow. And we lost Dr. Narendra Malhotra sir's father in this year, and that is why Dr. Jaideep ma'am could not join today. So we are heartfelt condolences to the family, to Malhotra families, and I think they have always been guided by Sir's father, who has set in this tradition of being a good doctor for all the Malhotra families. Then also today, I would like to express my feelings. Dr. Preeti Mond, who was supposed to be joining today as in our panel, she lost her mother. So again, heartiest condolences to the family, and we are there just to your support and our. I think the words cannot fulfill the void that is there, but ISAR Haryana is there with you in these times of I think in these testing times. So I think now we go on to Dr. Asha ma'am for her talk. Thank you so much, ma'am, for this late. For the last acceptance. I mean, we are really thankful to you to accept this sort of request from us. Thank you.
A very good afternoon. I would like to thank, first of all, Dr. Amit Patki and then Dr. Jyoti Malik for this opportunity. And thanks to the chairpersons, Dr. Maninder Ahuja, Dr. Gurneesh Singh, Dr. Poonam Lumba, and Dr. Manju Khurana. And also I would like to thank the whole team, Meenu Handa, Dr. Manju Dagar, and Dr. Lakshmi Goyal. And I know that your chapter is really, really very active chapter, and I've myself witnessed the installation ceremony and so many webinars. So I know that you people are very active, and it's okay, Jyoti. You asked me at the last moment to pitch in, so you all have to bear with me because I'm not very well prepared with this talk. But yes, I had the talk, so I thought I'll give it. So I'm going to talk on diminished ovarian reserve. And we all know that diminished ovarian reserve, though the ART has really progressed a lot, but still something which is not in our hands is diminished ovarian reserve. And we really feel very, very bad when we don't get the good number of oocytes, good quality of oocytes, and then naturally that affects the results. And so many times, even in young girls, we are seeing this. And it's not only that it is there in the old patients, it's there in the young patients also. And sometimes you start wondering what's happening, why these young girls, a beautiful young girl will come to your clinic and with all the enthusiasm, and she's thinking that she'll come to you and then you'll give her a little bit of treatment and she'll conceive. And then you really feel so sad that, oh my God, you have done a transvaginal sonography. And in this 27 years old girls ovaries, there are hardly any antral follicles. And that really makes you wonder what's happening. So overall incidence is quite a lot, and it has increased from 19 to 26% worldwide. Maybe the awareness has increased, or maybe there is something which is going on, and that is reducing the ovarian reserve. So maybe it is something to do with the environment, the genetics, the plastics, the endocrine disrupting factors. So we do not know, but yes, it is prevalent. So can we really do anything to prevent it? And though there aren't many things we can do, but still I think maintaining a healthy weight is very, very important. And healthy weight, healthy diet, all these things may help in prevention. Then avoiding tobacco, of course, that is important. And nutritional and lifestyle improvement may help in certain ways. And most important is that timely understanding your fertility, your ovarian reserve, and timely planning the pregnancies. That is important because that way, even if there is diminished ovarian reserve, but at least the fertility planning is over. And routine fertility checkups are very, very important. And especially today, like one patient came to me for termination of pregnancy. And when we see the ovaries, though this is a pregnant uterus and a pregnant woman, and very difficult to comment on ovaries, but still you know that these ovaries have got hardly 1 or 2 antral follicles. Maybe she's somebody who will have reduced ovarian reserve. Sometimes you see PCOS, so you say, okay. So I think even when termination, when people come for counseling of termination, that awareness of ovarian reserve should always be there, and that should be brought into your discussion. Not saying that you have got a reduced ovarian reserve, but at least this should be mentioned that some people, they may have reduced ovarian reserve and may afterwards find it difficult, because then afterwards they come and say, oh, I wish I had not gone for that termination. So that awareness about fertility assessment at every moment is important. Now, coming to nutritional factors and their impact on ovarian reserve. So overall, no significant effect of intake of soya products and isoflavone has been shown. Then vitamin D also has conflicting evidence. Dietary fat, there is no effect on AMH levels, non-significant reduction in FSH levels. And dietary fiber, there is conflicting evidence. Serum zinc levels were lower and copper levels were higher in women with premature ovarian insufficiency. So, and it has been found that obese poor responders could have lower pregnancy rates compared to non-obese poor responders. But when you compare all the things, then method of conception and outcome within 24 hours. So those people who really had the intervention in form of diet control, not a lot of difference was found in these patients. And what are the risk factors for premature ovarian failure? They are one, of course, very well evident, and that is age. Another is family history of early menopause. So always it's a good idea to ask the girls about how their mother's menopause was and when it was. Then genetic factors. There may be something like Turner's mosaicism or FMR1 gene mutations, which leads to FSH receptor blockage. Then disease that may cause ovarian damage like endometriosis. Endometriosis is very prevalent, and we know that advanced endometriosis is associated with low ovarian reserve. Similarly, pelvic tuberculosis may affect the ovarian blood supply, or that may also cause reduced ovarian reserve. So all these things. Then any ovarian surgery may have its impact on the ovarian reserve. Then chemotherapy, though these days the very good chemotherapeutic agents have come, but still and we all know that it does have its effect on ovaries, and especially women who have good AMH, they tend to have less effect. But if AMH is already borderline, and if these women get chemotherapy, then the the ovarian reserve goes further down. Pelvic radiotherapy in high doses may affect autoimmune diseases, like many women we see these days, and autoimmune diseases are being diagnosed also, and these are the girls who may have reduced ovarian reserve. Smoking, of course, has been very well shown to be associated with ovarian reserve, and many environmental factors, the use of pesticides, the plastics, and all these things may be affecting the ovarian reserve. So how to diagnose ovarian reserve? One is very simple, history of short cycles. Mostly we have found that these women, they tend to have shorter cycles. Then age, we all know. Then there may be abnormal ovarian reserve test. And if someone has undergone previous IVF and lower peak estradiol level after conventional stimulation on day 5, if it is less than 100, or on the day of HCG, if it is between 300 to 600, then you know that this is a patient who has diminished ovarian reserve or may have poor ovarian response. Then decreased number of follicles on day of HCG. Say date after all the maximum stimulation, your follicles were hardly 2 to 5. Or decreased number of eggs. You have retrieved the eggs and you found less than 5 eggs. And whenever you are trying to diagnose ovarian reserve, which is better, AFC or AMH? So which one to rely? So I feel they both are complementary, and both should be undertaken, both should be really assessed in their own merit, and then they should complement each other. So what is the advantage of antral follicle count? That it is easily, the moment the patient comes, you do a transvaginal sonography and you check for the ovarian reserve, antral follicles, and the diagnosis is in your hand. But then there is inter-observer variation also. And another problem is that intra-cycle variation are also there. Then maybe the patient has taken oral contraceptive in the past. So all these things may affect the antral follicle count. And AMH, best thing is that it does not have much intra or intercycle variation, and it does not it is not inter-observer dependent. So that is a very good thing about AMH. But sometimes if the AMH is not done properly, then you may get, and many times there are discrepancy. So in that case, if you see there is good antral follicle count, then maybe it is a good idea to recheck the AMH again. So, and it is expensive. So I think, but what happens is once AMH is low, your antral follicle count is low, and you counsel the patient, then she understands that yes, this is something which is diminished ovarian reserve, and here the action has to be taken fast. So there is a good documentation if you do AMH. Then poor ovarian response is defined as reduced follicular response resulting in low number of retrieved oocytes despite the high dose of gonadotropins. And many definitions are there, but mostly Bologna criteria is being followed nowadays. And it's important to follow one particular definition, because if you're going to publish some papers and do some studies, then that would be your reference definition. So at least 2 out of the 3 should be present, that is advanced maternal age or previous poor ovarian response or abnormal ovarian reserve test, or previous 2 poor ovarian response after maximal stimulation are sufficient to define a patient as poor ovarian responder. And this is another stratification which we all should know, and that is the Poseidon criteria or Poseidon stratification. And this has got 4 groups. So a rough way to remember is Poseidon group 1 and group 3 are the young patients, and Poseidon group 2 and group 4 are the older patients. Now group 1 and 2, these patients are having good ovarian reserve. They've got good AMH, good antral follicle counts more than 5, and AMH more than 1.2. And still, after maximal stimulation, you could get lower number of oocytes. So these are unexpected poor ovarian responders. Whereas group 3 and group 4, here already AFC is less, so you know about that. Already AMH is less, so you know about that. So here it is an expected poor ovarian response. You knew that yes, the chances of getting less eggs are there. So worst is this unexpected poor ovarian response where you are really not prepared, and then you feel so bad when you don't get sufficient eggs. And with this stratification, you can modify the regime accordingly. So if someone is a young and young with normal ovarian response, then you reassess the ovarian reserve test, or you check for genetic polymorphism, change the stimulation protocol strategy, increase the dose of FSH, and you may add recombinant LH also. So these are the ways to treat these patients. And if it is group 2, that is old patients who have got normal ovarian response, so normal ovarian reserve. So in these cases, again, you can try changing the stimulation regime. You add recombinant LH right from the beginning, and it is higher dose, say start from 150 units. And because they are older, so in these patients, you should consider aneuploidy screening of the embryos. So, and you can also, and especially in group B, you can also consider embryo accumulation. Then group Poseidon group 3, here it has been suggested that long GnRH analog is beneficial, and or you can sometimes use antagonists with pre-treatment with estradiol, or you stimulate with 300, and you stimulate with a higher dose, that is 300 units. And here you can do fresh transfer, or you can again do embryo accumulation and frozen embryo transfer. So measure of success is that in average, if you get total 4 to 7 oocytes, then chances of getting 1 euploid blastocyst is there, because this patient is a young patient, less than 35 years, who has poor ovarian reserve. But because she is young, so the embryos will be better. Now coming to the group 4, these are the older women more than 35 years. So here long GnRH analog protocol has been shown to be good, but you can use antagonist protocol depending on your choice, and stimulate with 300 units RFSH at the same time. add LH also for the stimulation. And again, here you can do fresh transfer or you can do embryo accumulation, or you can consider oocyte donation also if the things are very bad. And here measure of success is that at least you'll need 12 oocytes to obtain one euploid blastocyst. And when you come to the ovarian stimulation protocols and treatment, so there are so many choices, and especially about the adjuvants. So in adjuvants, you can use nutritional, lifestyle improvement, counseling, adjuvants, modify the protocols, egg cryopreservation, egg donation, and ovarian rejuvenation. So coming to adjuvants, it is androgens, growth hormone co-treatment, natural cycle or modified natural cycle. You can give high dose of gonadotropin. You can add glucocorticoid. You can use coenzyme Q. You can go for acupuncture, holistic medicine, PRP, in vitro activation of follicles, combination of many things. So everything is being tried. So that means that none of the thing really acts well, and you have to individualize the treatment according to the cost as well, what patient can afford, what is your experience, and how much patience does the patient have. Because if it is a bad case, then better to go for oocyte donation right in the beginning. But these days, everyone is well-read and they want their own genetic material. So be very tactful while counseling these patients, and try to first explain them how difficult the situation is, what all you can do, what are the expected outcomes, and are you ready to go through everything, or you want to go in for ovum donation. So do we do IUI for IVF in diminished ovarian response? Because the moment people see that, oh, this patient has got reduced ovarian reserve, why not straight away go for IVF, the fast track treatment? But I think still there is a place of IVF in diminished ovarian response. And this particular analysis of 462 patients with AMH less than 1.2, IVF did not lead to a higher live birth rate than IUI, and more than 40% of all IVF attempts did not lead to embryo transfer, suggesting that diminished ovarian reserve is not an indication for IVF over IUI. So I think the patients whom I particularly like to do IUI is those patients who have this borderline AMH, they are young and they have not tried for a long time, then they are a good candidate for IUI. Another group that I like is those patients who have hardly 1 or 2 antral follicles. And in them, I know that even if I do IVF and ovarian stimulation, whatever I do, I'm not going to get 1 or 2 eggs at the most, or I may not get the eggs. Then in these patients also, one may try with ovarian stimulation and IUI, and occasionally you may get result. So there is a place of IUI even in diminished ovarian reserve. Then there are many adjuvants we have already talked about, and a few years ago there was a lot of enthusiasm about androgens. They exert ovarian autocrine paracrine effect and increase the FSH receptors in granulosa cells, and for this either DHEAs was used or transdermal testosterone pre-treatment was used. And DHEAs was used for almost 3 months prior to the IVF, and transdermal testosterone was used 21 days prior to the IVF. So coming to DHEAs, the mechanism, exact mechanism is uncertain, but one simple way of understanding is that it creates PCOS-like characteristics and increases the LH. And it increases the small antral follicles and AMH levels. But the studies, the Cochrane review did not show any effect of DHEAs on successful pregnancy rates. And quality of the studies was moderate. So still more research is required to optimal duration of testosterone treatment. So all these things, initially there was a lot of enthusiasm, then the enthusiasm got low, and maybe someday some good studies will come up and they will say that no, still there is a role of DHEA and testosterone, though at the moment evidence is not in the favor of DHEAs and testosterone. Now coming to melatonin, melatonin is it is sort of beauty hormone, isn't it? And because people are using it a lot for anti-aging and sleep management and all. So basically, oxidative stress in peritoneal serum and follicular microenvironment can result in poor oocyte quality. And mechanism of melatonin is exactly not known, but it is said to reduce oxidative stress by acting like free radical scavenger. It attenuates cuproptosis and ferroptosis in aging cumulus and granulosa cells. And maybe this is how it improves the overall, it reduces the oxidative stress and improves the, decreases the apoptosis of the oocytes. And it also improves the circadian rhythm. And we all know that good sleep is also needed for reducing the stress. And stress and ovaries are highly sensitive to stress. Then coming to CoQ10, it is essential electron transporter in the mitochondrial respiratory chain. Mechanism of action isn't clear, but it acts as a scavenger of reactive oxygen species. And in a meta-analysis, it was suggested that antioxidants, CoQ10, melatonin, myoinositol, vitamin B, D, E, resveratrol, combination of acetyl carnitine, N-acetylcysteine, and alpha-lipoic acid. There was no difference in live birth rate. CoQ10 was the only antioxidant with a statistically significant increase in clinical pregnancy rates and oocyte retrieved. CoQ10 and melatonin were the only two antioxidants which improved embryo quality. So, and another thing which is being talked about a lot is growth hormone co-treatment. And growth hormone with gonadotropins in controlled ovarian hyperstimulation upregulates the intra-ovarian IGF-1 and augments the effect of FSH on folliculogenesis and possibly conception rates. Though it is an expensive treatment, overall, the results from various trials are inconclusive. Ideally, it should be used in growth hormone deficient patients, but I am also using this hormone, and sometimes you do get good results. We do not know whether it is real or is it just a placebo effect, but even studies are showing that there are some good effects of growth hormone. And recently, I was reading about a thin endometrium also. And it has been found that patients who are given growth hormone co-treatment with FSH, then in those cycles, the endometrium is much better. So even it has its effect on thin endometrium. Now, if this is a study, retrospective observational studies of patients undergoing growth hormone co-treatment, and here they divided the patients in three groups. One group was elderly poor responders, another was repeated IVF failure, and third was young poor ovarian responders. And what they found is that there was in advanced stage poor ovarian responders, they did not find any result, but there was some improvement in patients with previous IVF failure and in young poor ovarian responders. Now, the problem with all these studies is that nowhere they were really taken uniform dosage. So some people start with 4 units, some people start with 8 units. Some people start even before the ovarian stimulation, some people start just at the time of ovarian stimulation, and some people start in between. So there is no uniformity in dosage and administration of growth hormone. And maybe that is the reason we are not really able to produce a solid evidence about growth hormone. Then LH pre-treatment is also being considered for poor ovarian responders. And in this particular study, pre-treatment with recombinant LH, 150 units for 4 days was done. And this was followed by 400 units of recombinant FSH. And it was found that the cycle cancellation was less, results were better. And so it has been recommended in certain studies. Then another thing is all the RCTs comparing 10 adjuvant treatments, testosterone, DHEAs, letrozole, recombinant LH, recombinant HCG, estradiol, clomiphene, progesterone, growth hormone. And in this, when all these things were compared, they found that DHEA, CoQ10, and growth hormone showed better clinical outcomes in terms of achieving pregnancy, and a lower dosage of gonadotropin was required for ovulation induction. And this was a large network meta-analysis, and this was the result. Now, a few more agents are being marketed these days, and one is the commercial name is EQOQ, but these are NMN and L-argothionine in diminished ovarian reserve. So NMN is basically SIRT1 activator, and L-argothionine is NRF2 activator, and they are basically very good antioxidants, and they maintain endometrial health, enhance chances of successful embryo implantation. So SIRT1, it increases as the age increases, it goes down, and it is a major determinant influencing ovarian aging and quality of gametes. And NRF2 is present in cytoplasm of ovarian cells, and it is a natural antioxidant and regulates the level of peroxidases and antioxidant substances. It plays a powerful cytoprotective role to protect DNA, proteins, lipids, and other components. So besides the adjuvants, one can modify the protocols also. And there are so many protocols described in the literature. So out of that, one important thing is that you can use FSH, which has got more LH activity like HMG. And most of us, we do use it because we know that in Poseidon 1 and Poseidon 2 cases, if you add LH, then the results are better. So HMG or LH supplementation may help, though still there is insufficient scientific evidence. And then how much should be the dose of gonadotropins? Because many times we keep on increasing the dose and the results are the same. So we are just wasting the gonadotropins and increasing the cost of treatment. So patients with predefined low ovarian reserve would have similar outcomes even with milder approach. So people have tried increasing the dose, and it has been suggested that gonadotropin of 600 units does not improve outcome of IVF cycles compared to 450 units. And especially if there is a very, very low ovarian reserve, then maybe in these patients, modified natural protocols should be used. And coming to GnRH agonist, GnRH antagonist, and flare-up regimes, the studies have not shown any difference. But one thing we know that when we use long protocol, then chances of asynchronous follicular growth is less. And in one particular study, they've shown that GnRH analog is much better overall in these patients. So some people still like to use GnRH analog in diminished ovarian reserve. Then minimal stimulation protocol, as I've already mentioned, they are cost effective if the ovarian reserve is very low. Then there isn't a point in really increasing the dose. Instead, one can go for minimal stimulation protocol. But overall, it results in fewer but higher quality of embryos, lower pregnancy rates, but it is cost effective. Then duo stimulation protocol, I think many of you must be using. Even I have used it in certain cases. And the thing is that we now know that there are various waves of follicular recruitment, and those waves can be utilized. So in the first wave during follicular phase, you can stimulate, and then again after 5 days of the oocyte retrieval, you can start the new stimulation. And overall, the results have been good. You get higher number of oocytes and better quality of embryos. In my cases, what I found is that the dose, gonadotropin dose, was more in the luteal phase stimulation, but I've done very few cases, so I can't really comment much on this. Then double stimulation, this duo-stim protocol has been shown to be good, and has shown to improve the oocyte recovery rate, blastocyst rate, clinical pregnancy rate, and less pregnancy loss. Then this is a delayed start protocol. Here in this particular study, transvaginal sonography was done on day 2, and this was followed by GnRH antagonists for 7 days. And stimulation was started on day 9 with gonadotropins 450 units. and GnRH antagonist was added when 12 millimeter follicle was there till trigger, and fresh transfer was done. So in this delayed start protocol, ovarian responsiveness was good, and it may result in more mature oocyte retrieve, but it is longer and expensive because GnRH antagonist itself is quite expensive. Then in this short agonist protocol, here they have done pre-treatment with estradiol starting from mid-luteal phase. Then from day 2, they started decapeptyl for 7 days and they stopped. And then 300 units of FSH was started from day 4. And after 7 days, antagonist was started till trigger. And the conclusion was that it is short and original protocol strengthening the therapeutic arsenals of poor responder that may offer promising results for those patients with low prognosis and previous failed IVF. But still, the results must be failed with a randomized controlled trial. Then corifoliatropin alpha, initially it was thought that it is going to be very good because high dose is given and it will recruit more follicles. But overall, the studies have shown that they did not find much benefit by using corifoliatropin alpha. Then letrozole has been used in various ways, and one way is combining letrozole with gonadotropin. So here letrozole and GnRH antagonist was used, and in letrozole group 2.5 milligram letrozole was given daily, and recombinant FSH was also given. And outcome was that the use of letrozole in GnRH antagonist cycle does not improve clinical outcomes in poor ovarian response undergoing ICSI. So they did not find much difference by using letrozole co-treatment with gonadotropin. But in this other study, what they did is they gave letrozole first, and then they started the ovarian stimulation. So letrozole was given from day 2 to 6, 5 milligram, then 225 to 300 units of gonadotropin was started from day 5, and GnRH antagonist was used. And here the clinical pregnancy rates in the modified letrozole group was significantly higher. So they have shown that this protocol may be more effective. Then Andro-IVF is a Khichdi protocol where they have used testosterone, they have used letrozole, they have used HCG and everything. So this involves 2 phases. So in the pre-IVF phase, that is the month prior to stimulation, here you give transdermal testosterone 25 milligram on alternate days from day 1. Then letrozole 2.5 milligram daily orally, and HCG twice a week. Then in the phase 2, you use recombinant FSH 450 units and GnRH antagonist as usual, when the follicle is 14 millimeter and trigger is given with HCG. And the result was that it improved number of oocytes retrieved and clinical pregnancy rate. Then this is another study. Another thing is what trigger to be used. And these days there is a lot of enthusiasm about dual trigger. And this particular study showed that dual triggering is associated with better IVF outcomes. But this is another study which showed that dual trigger is not systematically useful even in poor ovarian responders, and especially in Poseidon group 3 and 4. They found that HCG was better and HCG gave better oocytes. Then recombinant LH supplementation has a significant effect on increasing cumulative live birth. So another thing is that we all are talking about microbiota and probiotics for PCO. But again, this study says that even there is influence of gut microbiome on the ovarian aging also. So this also needs to be really studied. And rejuvenation medicine is picking up in a large way, and PRP, I'm sure you all must be practicing, and it has got its own effects. And preparation is very important. It has to be aseptic, and as soon as the preparation is made, within 3 hours you should inject. It can be injected laparoscopically, or it can be injected on TVS. And when the ovaries are very small, then I liked one comment by Dr. Nandita Palshetkar, and what they do is they stimulate the ovaries using clomiphene or letrozole. And then they, because that helps in localizing the ovaries very well, and then they inject the PRP so in the ovary. So that I think is a good tip. And this is how it is being done laparoscopically. And then the studies have shown that the results are good. It is a good viable option. But again, which method should be used, what should be the route, this all needs to be researched more. Then coming to the bone marrow stem cells and the bone marrow, that is again very important. And especially bone marrow transplant has been used to rescue ovarian, because you get mesenchymal cells, and they help in rejuvenation. But this is all again to be done under research setting and in the centers who have expertise in doing this. Then, so conclusion is, diminished ovarian reserve is a very frustrating situation both for the clinician and the patients. Attention should be paid on healthy lifestyle prevention, which also includes fertility counseling, assessment, and timely pregnancy planning amongst the youngsters. Adjuvants, if taken properly and adequately, may help up to some extent. Then knowing various protocols and individualizing the stimulation is important. Ovarian rejuvenation is the futuristic and promising approach. Ovum donation, though not practical approach, but all the efforts should be made to use, though is a practical approach, but all the efforts should be made to use the self-eggs. So at the end, I would like to thank you all for the patient listening. Thank you very much.
Thank you, Dr. Asha Baxi. I think that was a wonderful, wonderful, exhaustive coverage as far as the premature ovarian insufficiency and infertility is concerned. So nothing to beat that. You have highlighted role of all the adjuvants and all various stimulating protocols which are there. Some are effective, some are not. So once that is an excellent, again, 3 cheers for you for that. But along with premature ovarian insufficiency comes another aspect of women's life, that is the premature menopause is also there. So this is already indicating a very big red flag. No, it's an indicator that the woman is going into premature menopause. And that is where, as a gynecologist, we have to know that we have to counsel her for that and put her on treatment for that premature menopause once she has completed her family. So whatever, if we are able to give her a family by even by ovum donation or something, she needs the follow-up. Please, please, please don't stop her following up, because once you have given her a child, she needs to look after that child. And if we don't give her treatment now, she'll end up into might be coronary vascular disease, or might be osteoporosis. Early life expectancy is decreased, quality of life is decreased. So once we have finished with the fertility treatment, we should put her on menopause hormone therapy. These are the international guidelines where they have to be continued with the menopause hormone therapy till the natural age of menopause, because she's already going into between 35 and 40 years of age, or 41, 42 years of age, where she has come to us, but before the natural age of menopause. So we have to give her the same up. You have to investigate her continuously, follow up with the lipid profile, blood sugar, because that is what she's going to end up with, diabetes or coronary vascular disease. Then osteoporosis, she has to be followed up. She has to be given the calcium, vitamin D, of course. Resistance exercises are very, very essential in this group of women. And then for osteoporosis, we have to do that DEXA scan earlier in these women. Normally, we tell them within 5 years of menopause, because they will be already menopausal. So we had to do one basic DEXA scan, then repeat after 2 years. And if despite the menopause hormone therapy, she is having osteopenia or osteoporosis, then she has to be given added bisphosphonates and other drugs. So again, Dr. Asha Baxi, I congratulate you for this excellent, excellent talk on this thing. And now I have to congratulate Dr. Jyoti Malik, Dr. Amit Patki for continuing with it. I have known Jyoti Malik for a long time because she was my secretary when I was the chairperson of Haryana chapter, and I have never seen such an enthusiastic young lady. And she's taking the lifestyle modifications in a very serious way. And you can see her videos also. And Dr. Meenu Handa, Dr. Dogger, and Dr. Gurmeesh Singh, who is there as our co-moderate chairperson. Others, I think, are absent anyway, could not make it. And I have my condolences for Dr. Malhotra and Dr. Jaideep Malhotra and Dr. Narendra Malhotra, because he was like a father to me also. I used to call him Papa only. And I could go to their last rite. So that was my privilege at that time. And I'll hand over to Dr. Gurmeesh Singh for further comments, please, sir.
Thank you, ma'am. First of all, I thank Dr. Jyoti Malik and the team for allowing me to associate with this webinar. And thanks, Dr. Asha Baxi, for giving such a whole panorama view of POI. But my observation are like this, that after 35 years, when we use these self cycles and with the God's grace, they become pregnant, the chances of abortion, chances of preterm deliveries are more. So in the end, we have to, I think, counsel her more. Even if you become pregnant, even then you have to face these things, that there will be higher chances of aneuploidies, higher chances of abortions, higher chances of preterm labor. So sometimes it is, sometimes that time they tell you कि अगर आपको पता था तो आपने पहले ही किसी ओवम डोनर को क्यों नहीं यूज किया. So I think that should be taken into consideration. Overall, ma'am, it was a very good webinar, ma'am. Thanks, ma'am.
And congratulations to Jyoti Malik again for selecting a very, very important topic. I think this is the hot topic these days now.
Thank you so much, ma'am.
Was I audible?
Yes, ma'am. Thank you so much for your inputs, ma'am, because I know you were the the very, very apt chairperson for this talk. Actually, that is why I chose you, because I know you are into menopausal, on the MHT part, you have a strong command, and your inputs about carrying forward these women after infertility is also our responsibility. And how do we take care of their bones, their heart, their for future health, because not only making them pregnant, after that also is something which we should not forget. So thank you so much, Dr. Maninder ma'am, Dr. Gurneesh sir, and Dr. Asha Baxi ma'am. It was amazing. You're exhaustive. I think if you could share that PPT, we can share it on the group with our ISAR Haryana, because it was very exhaustive and it covered everything. So thank you so much, ma'am. Now over to our to Dr. Lakshmi for the second half of the proceedings.
Thank you, Dr. Jyoti. Thank you, Dr. Asha ma'am, Dr. Maninder ma'am, Dr. Gurneesh sir. Now let's move on to our next session, that is the panel on the POR. And for the panel, I would like to invite our moderators, very dynamic moderators, Dr. Jyoti Malik. We all know her. She's a chairperson of Haryana chapter of ISAR. She's this.
Dr. Lakshmi we'll save time. Yeah.
Right. So we all know her. She's a very dynamic person. And along with Dr. Jyoti Malik, we have our Dr. Meenu Handa. She's another very, very dynamic person. She's a secretary of Haryana chapter of ISAR. And I would like to invite the experts for the.
Dr. Meenu is expert.
Yeah, Dr. Meenu is the expert. So the panelist, Dr. Divya. Dr. Divya is here.
Yes, Dr. Divya is there.
Dr. Divya is a senior IVF specialist at Accord Hospital. Dr. Rakhi Goyal,
Dr. Rakhi Goyal is here. Dr. Shilpa Sharma.
Yes.
Dr. Shilpa Sharma is here.
Yes, I'm here, ma'am.
Okay. Hello, Dr. Shilpa.
And last but not the least, Dr. Lakshmi Goyal is also there.
Yes.
So
I am
we
also.
have all, but Dr. Pooja will not be able to join. No, not Dr. Pooja, sorry, Dr. Preeti won't be joining today. So we have our 4 panelists and our expert. And actually, most of the part has been taken care of. Yes. So
Yes, it's already been discussed. Ma'am has already taken all the.
ma'am has really discussed it, but we'll just
Everything.
So it has been made very, very easy for us. So we will just rush through our panel. We'll revise whatever ma'am has taught us. So we have this 36-year-old lady who comes to us. She's married only for 2.5 years. She has regular cycles and she's anxious to conceive. Now, Dr. Preeti is not there. So anybody can take it. What exactly do you make out of it? I think Dr. Meenu can take this. That when Dr. Meenu, we get this 36-year-old and how do we start talking to her? What all we talk to her? How much do we talk to her? And what is exactly in our mind going on when we see her? So the factors of concern and what do we think, what we are going through, what we might be dealing with.
Thanks, Dr. Jyoti. So this particular patient, the moment somebody is walking in and she's 36 years of age, the first concern is the low ovarian reserve that comes into our mind, that we should be at least ruling that out. Second, she's been married for 2.5 years. So is there any other history that could give us some indication about maybe some quality of oocyte quality, which could be like an abortion, history of abortions could be there. So my first concern would be her egg reserve and any history of abortions or anything which is there. So that would be the very first thing.
Yeah, so definitely at 36, after the age of 35, the fertility is declining due to the reducing of the primordial follicular pool. And therefore, there is not only ovulation that has been happening all this while, also follicular atresia is happening. And we only have a finite number of germ cells. And the maximum is around 6 to 7 million at 8 weeks. At 20 weeks is the maximum. At birth, it is 1 to 2 million. And by the time puberty is there, we have to start our aging now from 300,000 to now going up to, at 35, we are left with 25,000 eggs only. And at menopause, it is 1,000. So when we see this, that at 30 years of age, only 12% of the eggs are remaining. So that is a little, I found it very scary that these days girls at 28 and 30 years, they say that it is not the time for them to conceive. They still have a lot to plan. And they are starting their life now, this obstetric career with only around 10% of the eggs that God has provided with. And by 40, it is just 3%. So this is what is happening. We at between 20 to 30, we have the best timing to conceive. We have the optimal fertility. 30 to 40, the fertility is declining. And nearly after 40, there is end of fertility and we are going into perimenopause. So the quality of oocytes is decreasing with the age, and the number of oocytes also is decreasing. So this is what is happening, and that is why we why these ovaries, they are now, why we are worried is because they are resistant to stimulation. There is reduced amount of DNA left, and there is telomeric shortening happening. So, and meiotic errors, which can lead on to all these Down syndrome and lots of miscarriages that Dr. I think Dr. Gurmeet was talking about the miscarriage risk of problems during pregnancy and all. So this is what the aging ovaries are. There is increased granulosa cell apoptosis. There is increased oxidative stress. The mitochondrial energy is becoming lesser. The theca cells are aging, and the euploid blasts decrease as the age increases. So there are many changes that are occurring with the ovaries. So what all tests, Dr. Meenu, we should advise them once we see such a case, that what all tests you start with, what you recommend to them?
See, the very important thing, as you've just mentioned, is that somebody who's crossed 35 years of age, we also understand that this is the ASHRAE guidelines and the WHO, that they should, even if they're married even for 6 months and they've been trying, they have to be at least started to at least test themselves for what is their current fertility. And we need to expedite their chances of getting pregnant faster. That is very important. So for that, the tests which we are looking from the wife's side would be her ovarian reserve tests. That is generally recommended in the follicular phase, which is mainly the AMH and FSH. And then we are also looking at a complete ultrasound pelvis of the women, where we are looking at the anterior follicular count, which is again a very important ovarian reserve test. Second would be from the husband's parameters, which is the semen parameters are to be done. If this is fine, I do not really recommend in my practice tubal testing straight away. I would first like to add some treatment to it. And then if she's not still conceiving, then probably I would also be testing for the tubes. And
okay,
yeah,
so
I think this is the way we'll start.
2.5 years. Yeah. Should we be, I mean, that is what, should we be asking them to go for a tubal test or no? At this, I mean, since you suggested that you take some bit of time and that way.
So even for the tubal testing, even if we assume that one of the tube is patent and they have not done anything else, I would first like to initiate some kind of ovulation induction and a natural try. And if there is a semen parameters which are deranged, because that's very, very common in the clinical practice that we are seeing, we might take them for an IUI. I personally take them for an IUI 1 or 2 cycles. If it is not happening, then a tubal testing is also suggested. So that way, it gives me a month or 2 to get more familiarized with the patient, as well as they get more comfortable coming, to the clinics, getting them self-tested and getting to understand their fertility, and then proceeding for the tubal testing. It is definitely not pushed till the end, but yes, within a month or 2, definitely tubal testing is a part of the routine that should be done.
Right.
Jyoti,
So you, hello?
I would beg to differ.
Yeah,
I would say we should explain to the patient what is the role of the fallopian tubes and whether they want to go for it in the starting or not. Many patients are very scared of doing an HSG because they have heard about it's very painful and all. But we have to think about the medical legal angle also. If we are undergoing, especially if the patient is proceeding for an IUI, we should at least offer an tubal testing. And if they refuse to do it, we should maybe document it that patient has refused to do it right now. They want to do maybe 1 or 2 cycles of IUI, and then if not successful, then they want to do it, because we have seen multiple cases in which the patients then later on say that, why didn't you proceed with the IUI without tubal testing first, if the subsequently if the test come out to be abnormal. So I think we should offer, explain it, and then leave it to the patient.
See, IUI, when we are looking at IUI with gonadotropins, it is definitely recommended that you do the tubal testing. And prior to, if you're doing a gonadotropins to an cycle. But if it's simply an ovulation induction, letrozole, then at the very first go, you need not even, ASHRAE doesn't recommend doing a tubal testing with an ovulation induction IUI. But it definitely recommends a gonadotropin if you have added. It is always better to do the tubal testing. So I think yes, but counseling is very, very important. They do the counselings and then proceed.
So both of our actually panelists are right in their own sense. The only way how we talk to the patient and explain to them, Dr. Rakhi has suggested we may advise them. We may tell them that okay, these are the things that need to be done.
Yes, even I think that like you should always go for a tubal patency test. At least you should counsel the patient before you go for an IUI. Because IUI anyway is a procedure. It's not like just ovulation induction and timing of intercourse. So it involves some amount of money and time, and so money and time, then the expectation also rises. So it's all in my practice also, I prefer to go for a tubal test, patency test before going for IUI. At least I'll counsel. I'll encourage, counsel in a way that I'll encourage the patient to get it done.
Yeah.
In
So
some
all
times,
of yes.
sometimes
Have
even
our
in the
practice of
patients who
talking
don't
to the
have a
patient.
he don't have a history which might suggest any that the tubes might be blocked, but sometimes it comes out to
Yeah,
be blocked
sometimes it comes
subsequently,
as a
even
surprise.
if there
Yeah.
is no other
Yeah,
suggestive
so
history. That is.
if we suspect PID or anything, definitely we expect
Yeah.
that, or there's any history of prior miscarriages,
Tuberculosis also sometimes.
tuberculosis. So those are the cases. Then we might go in for a tubal testing earlier than later. But yeah, sometimes most of the times, in fact, I also have found that patients do not like to go for a HSG because they have heard that it is
They've
quite
heard it's
painful.
painful.
But definitely,
Can I, Jyoti, can
so
I
it
add
can
something
be
here?
done.
Dr.
Yeah.
Jyoti, Dr. Maninder wants to
These are
add
the
something.
ovarian reserve tests that we need. Yes, yes, ma'am.
Yeah, Jyoti, I wanted to add here something. In their own way, both the panelists are right. But there is something, I think, which is not very popular now, but that has been given as a guideline even for
Sonography.
SFM, that is sono infusion sonography. That can
Sonography,
be
right.
done as an
Hysterography.
OPD procedure. You just don't have to put in a catheter, put in saline, do your TVS, and just look at that. 50 to 100 ml of saline is also going, even 20 to 30 ml will tell you whether the fluid is going through tubes or not. So that is a very simple test and should be done, I think, by all. Everybody can try.
And
There's
we
no
are
learning
doing
curve
it in
at all.
the
There's
practice,
nothing at
yes.
all. So one thing. Second is, yeah, about doing the tubal patency test or not. I remember my first case, which I done years back, that I had done 5, 6 IUIs and she did not conceive. I told them to go for IVF. And then they said, no, madam, try again. Because before then I will do hysteroscopy. At that time, I was not doing this thing. So I did the hysteroscopy and there were 2 small polyps on the both tube, they were just sitting carnal and just like flags they were making. We just removed them. It was a simple thing. And the next IUI cycle, she conceived. She again came to me after 3 years and then she conceived in the first cycle itself. So I think these procedures, which are minimal, should be done because even IUI has become very costly now. After the registrations and everything, all these things are costing a lots of money now.
So, yeah, that was a very good input by Dr. Maninder, ma'am. So definitely we can use our practical experience, we can use our charm, we can use our counseling skills. We can at least put into the patient and then it is up to them to decide. Though guidelines, as Dr. Meenu suggested, do not clear cut tell us that we have to go in for a HSG straight away only if we are just doing a ovulation induction. Now, what is the AMH level that you would consider to be normal or below which we should start feeling concerned? What AMH levels do you take as a cutoff, Dr. Meenu? Or anybody, Dr. Divya, whoever can take this.
So definitely it has to do something with the age, but on an average, like Bologna criteria says 1.1 for poor ovarian response and Poisson is like 1.2. So something less than 1 is definitely alarming. but like 1.2 to 1.5 can be very much taken as a cutoff. And in young patient, again, if it is like very young patient, it is even less than 2 in a patient who is in her 20s, then it should set an alarm. And definitely will have to correlate with AFC,
Right.
because antral follicle count is something you are seeing by your eyes. So that is there.
So, yes, so we are taking all these into consideration, the AMH, the AFC, and the age. All
Age in
these
total,
three
yeah.
things in total we are seeing, looking at also
Yes.
not only the AMH, because sometimes AMH may not be the as predictive as AFC is when we are doing our own ultrasound
And
scans.
even the cycle length, a very short, Dr.
Yes.
Like Asha Baxi ma'am, she had
Yes.
explained it
Yes.
all. She has said it everything. We are just repeating that. A short
We
cycle, young age, and I have seen those who have some sort of autoimmune disorders, like young diabetics. They will have poor ovarian reserve. Those young girls with endometriosis. So many things will have to take into criteria before like coming to a conclusion.
But Dr. Jyoti, I just want to add one thing,
Yes.
there are many times where a lot of young girls who are actually diagnosed as PCOD based on irregular
Yes.
cycles. But many times when they come to say to us and say, oh ma'am, we are known case of PCOD. But when you look at their AMH, you're looking to find a typical PCO. But that's the time when you see that these are actually poor ovarian responders who
Reserve,
actually
yes. And it has
reserve.
happened with me also so many times.
Yeah.
Like one patient, I still remember, she was to get married, and then when I got her AMH and everything done, then it was less than 1. So she was a case of premature ovarian insufficiency. So
Yeah.
she was sort of devastated by once I broke the news, but it is actually happening. They are misdiagnosed as PCOS because they are not getting their periods on their own, and they are getting multiple cycles of meprate and withdrawal bleeding, and still they are not having. Actually, once you give them a OCP, it's like HRT for them, then only they will bleed. So it is there. It is already happening.
Right. So, Dr. Minu, I would like to you to at least tell us how do you do your AFC count, what all you look, and what exactly, how many follicles after below which you feel that this is a case of POR, DOR, whatever.
So I think antral follicular count, we are generally calling patients in the early follicular phase, which is somewhere between post her periods, day 2, day 3, day 4, a little earlier, the better. And here we do the transvaginal ultrasound, is always more reliable than a transabdominal. And we are looking at the small antral follicles, which is between 2 to 10 millimeters, because these are the follicles which can be and which would be recruited, and they have they're going to respond to the FSH. So generally you see the sweep that you're going to take. Either I generally take it from lateral to medial, up to down. So these are the two sweeps, so that you're not counting the follicle again and again, not miscounting the follicle. So that is how we are going to do from cycle day 2 to 4, antral follicular 2 to 10 millimeters, 2 sweeps across, horizontal and vertical, and transvaginal scan. In any time, if you feel, generally in poor responders, what happens is that if you're calling them by day 4 or day 5, that's a time when we are going to have a dominant follicle sitting there. So that is again one thing that the AFC would not be very accurate. So that's the reason why the sooner the better, second or the third day.
Absolutely.
And any follicle count, which is going to be less than 4 to 5, that is going to, again, this is AFC, AMH, and age. They are the 3 important parameters which we are going to consider together. There's not one single parameter which can predict. So all 3 together will be able to give us a better correlation of a egg reserve for a patient.
Right. So now we move on to certain practical terms. Dr. Shilpa, we call what is DOR, diminished reserve? What is premature ovarian insufficiency? What is poor ovarian responder? So these things, once we go, and also about the Pozidyan and the Bologna criteria, we just talk, this is all theoretical, but let's just make our fundas clear But what is exactly DOR? What are these terminologies? What do they, how different they are?
Starting with, thank you, Dr. Jyoti, for the question. Now, starting with the first terminology, which is the poor ovarian reserve or the diminished ovarian reserve. So it is basically the reduction in the quantity of the ovarian reserve pool in a reproductive age woman. Now, the second terminology, which is a poor ovarian responder, is basically, it is the terminology which is used to describe a woman, a regular ovulatory woman basically, who would have responded poorly to her ovarian stimulation in respond to someone of the similar age group. And thirdly, the premature ovarian insufficiency is basically the cessation or the basically cessation of the ovarian function in a woman who is less than 40 years of age. Now, coming to the terminology, which is the POI, the premature ovarian insufficiency. The ESHRE gave a definition where how to define the POI. Now, that would be someone who has had a cessation of amenorrhea or cessation of a menses amenorrhea or oligomenorrhea for 4-month duration, and an increase in the FSH values more than 25 international unit per liter. Now, coming to the POR, as Asha Baxi ma'am has already said in her talk, that basically there was a lack of consensus in the definition and people did not know what to actually, call a POR as. And hence, ESHRE came up with a definition, the Bologna criteria in 2011, which actually says that if either two of the three criteria that were actually given by the ESHRE are present, then we consider the person to be a POR. Now, the three criteria that were given by the ESHRE were first, that either there is the woman is more than 40 years of age, or she has another factor, which risk factor for POR, or she has had an response or a previous POR response to a conventional stimulation. That is, she has less than 3 or 3 oocytes were retrieved with the conventional stimulation protocol, or there is an abnormal ovarian reserve test, as Divya ma'am had already told. According to the Bologna, it is the AMH is less than 1.1 or between 0.5 to 1.1, or the antral follicle count is 5 to 7, or if or there that you have had 2 conventional stimulation and patient has responded poorly after maximum stimulation, that criteria alone itself is also sufficient to diagnose the patient as a POR. Coming to the Poseidon criteria, basically Poseidon is the patient-oriented strategies encompassing the individualized oocyte number. Now, the patient was divided into 4 groups, and in which the group 1 and group 3 are basically young patients less than 35, and 2 and 4 are basically more than 35. 1 and 2 are basically unexpected poor responders, whereas the 3 and 4 are where you expect them to respond poorly because the ovarian reserve testing would be poor. That means that either the AFCs would be less than 5 or the AMH would be less than 1.2. The Procedure group 1 and 2 are further divided into the group A and B depending on the number of the oocytes that are retrieved in them after a standard ovarian stimulation, where the group A's would have lesser oocyte retrieved, less than 4, and B would be 4 to 9 oocytes that are retrieved in them. So that is how we do the Poseidon grouping, basically.
Right. So let's say if our patient, if this lady that we are talking of has a AMH of 1, so she comes now in group 4.
Yes, group 4. Because she is more than 35 and her AMH, that is the ovarian reserve test, is in an expected low group. So she would come into a group 4, Poseidon.
Right. And if she was like AMH of 1.2, so she is
Then group 2.
Group 2.
Group 2. Group 2.
Right. So now we discuss this case, and let's say she is So as very nicely explained by Dr. Shilpa about these groups, basically these, and also Dr. Asha has told us, these are the two young groups, and 2 and 4 are older ones, more than 35. And these have the adequate ovarian reserve 1 and 2, and 3 and 4 have poor ovarian reserve. So these are the cases where we expect, because of the poor reserve, we expect that we are going to have difficulties stimulating them. We are going to get lesser follicular pool and lesser oocyte number. And that is why we need to sort of do a lot of pre-workup and maybe add many other things so that we can add adjuvants and all to these cases. Okay, can somebody also tell us about ART calculator, which can give us some tell us some idea about what we are going to get? What exactly is a ART calculator?
The ART calculator was actually given by the Poseidon group only in the year 2019. Now, this was a novel predictor method in which you could actually, put the age and the source of the semen, and you could assess what number of the oocytes would be required to get one euploid blast. Now, why they gave this number of one euploid blast is because they said at any age group, whether the patient is young, whether the patient is older, this one euploid blast would give you a pregnancy rate of 50 to 60%. And that is why they wanted to come up with a figure where they could get an oocyte number that the patient and the physician could actually discuss and tell them and come to a success probability at that what is their chances of getting pregnant with what number of oocytes that are possible.
Yeah, so for counseling, it is very important because we can give them we can talk to them on some these definitive results that we can give them. So it is an ideal tool to counsel the patient about their prognosis when we are starting them on ART, and subsequently at the time of oocyte retrieval, where some patients might be counseled to go directly to a luteal phase stimulation, like a duo stimulation, so that their chances of having at least one euploid blast is there. So, Dr. Lakshmi, now we come to this young 26-year-old married for 3 years. Her all other tests are normal, but her AMH is 0.9. Her AFC is 4 on both sides. So what is the prognosis and what will be your approach for this particular case? Whereas you have another lady who's 40-year, married for 2 years, all her tests are normal, but similar AMH and AFC. And what would be her prognosis? So the AMH AFC are lower, and this is 26 and 40 years. So Poseidon is this one now.
Yes, the first one will fall in the Poseidon group 3, and the second one will fall into the Poseidon group 4. So we are expecting, because the AMH and AFC is low, so we would have we would expect that the response that we'll get will be low response. So but the prognosis in a younger female, that is the age is less, then the oocyte quality is better, the risk of aneuploidies is better, the grading of the embryos is better. So the prognosis will be better in this group, the Poseidon group 3, as compared to the Poseidon group 4, in which because of the age, the risk of aneuploidies, the oocyte quality and the embryo grading will not be as good as in the younger patient. So the counseling, so the counseling will be very important in both these patients, because in a 40-year-old female, we'll have to tell the patient, counsel the patient for these risks, the risks of abortion, the aneuploidy risk, and the low prognosis. We'll have to counsel her.
Yeah, so this young girl, we can still give her an option of IUI. Yes. And attempting at least 2 to 3 IUIs. But here we have to rush her, and we have to give her a prompt IVF. because here even the oocyte quality is compromised. Here we have at least the AFC AMH is low, but at least the quality of oocyte is good, so we can still
maybe one cycle of IUI we can still counsel her for, and then if that doesn't work, then we can counsel her for an early IVF because of a low AMH.
Yeah. So what are the risk factors for diminished reserve? We can again just revise them very briefly.
So first of all, the age is one of the most important factor. Then if like in our history, we always ask about the family history of early menopause, and also in these patients we do a karyotype test because to rule out the Turner's mosaic and the Turner syndrome, especially in a young patient with poor ovarian reserve. Then history of endometriosis is very important. I had a patient, she was 29 years old, and like she had an endometriotic cyst of 2 centimeters, and she was just married for 6 months. I got her AMH, it came out to be 0.9. So I told her it's better that you get, you conceive soon. So endometriosis is one, and then smoking is a very important factor which we have to counsel the patient about. Then iatrogenic, any history of surgery, any ovarian surgeries or pelvic surgery, history of chemotherapy, radiotherapy is important. And then any autoimmune diseases is one of the important risk factor. So we always rule out the hypothyroidism or hyperthyroidism and diabetes in such patients, and always get an anti-TPO antibody test also if they have a if they are suffering from hypothyroidism. And then infections, of course, genital tuberculosis, PID, then Fragile X, mental retardation Fragile X syndrome is also one, and then FSHR polymorphism, and especially in young females. These females do not respond to the ovarian stimulation very well, so we must rule out that as well. And then autoimmune, we have already discussed.
Absolutely. So now we come to Dr. Rakhi. Since we are running out of late, I think we'll do it faster. So now once you've established the diagnosis, how would you counsel and how would you manage her?
We are discussing both the cases, not the young and the older one.
Let's say we are talking of the older one now.
Okay.
Older one with a lower AMH.
Basically, breaking the news and counseling is very important, because in the older age, patient does not accept that they have been trying for a very short while. And when you counsel them straight away for IVF, they are surprised and they have to accept that news. So we have to explain what are the realistic chances of conception, the risk of aneuploidies, and we can offer them PGTA also, because it shortens the time to conception. These patients have this associated sometimes endometriosis, adenomyosis, fibroids also, and you plan a down-regulated embryo transfer, though that also consumes some time from the OPU to the transfer time. So PGTA helps in saving this time also. And you have to explain, if the patient does not opt for a PGTA, you have to explain the risk during pregnancy of having aneuploidies and need for invasive testing also, and the further risk of miscarriages. So after proper counseling, we are straight away going for a IVF is the best option. And I would not offer expectant management in this case. Adjuvants, generally what I use is, I do a estrogen priming in the previous cycle, estrogen prime cycle for synchronization of the follicles. And I do a short hair protocol or an antagonist protocol. Sorry?
Okay. Estrogen, when do you start? What dosage for how long?
2 milligram twice a day after confirming the ovulation in the mid-luteal phase till the day 1 of the periods. Then generally we do a antagonist protocol with the use of recombinant FSH. And if the patient is affording, we can offer her recombinant LH, or we do add some HMG for the LH activity. Along with that, we can put her on testosterone gel from the previous cycle as an adjuvant. And if depending, we can go for a fresh transfer also if the patient lining is okay and progesterone is low and the patient has not opted for a PGTA. We can offer her a fresh transfer also, or we can do a cryopreserved cycle. Always we can offer donor oocyte IVF. We should do a counseling because patient has to see their financials also, and otherwise they will say that we were not given the option of going for a donor egg oocyte. So after adequate counseling, IVF self or a donor egg IVF. This is what.
So you would like to take her for IVF.
Yes.
Anybody would like to go in for a controlled stimulation in IUI? Anybody? Dr. Divya, Dr. Meenu?
Sorry, this was the younger patient.
Oh, no, we are just
the older one, older
the
one.
older
first
one.
thing.
40
first
years,
one that
maybe
we started
one cycle we can try with after counseling.
Yeah,
If the
we are
patient
talking
is
about
not ready, but we will always have to say that the first choice is IVF. If the
Okay.
patient is not ready, I will never say the first choice is IUI. First choice has to be IVF because there's so much, I mean, she doesn't have a reserve left. So whatever is there, it should be used in the best possible way. But then if she insists, I can go for a cycle of IUI or till the time she is preparing herself.
Yeah,
IUI,
I would
how many cycles maximum IUI if you are going ahead?
One IUI, only one cycle I'll go. I'll tell
Okay.
her to.
And Dr. Meenu, would you like to try only
I
IUI?
agree. No, I wouldn't like to try IUI. I would definitely take her for self-cycle IVF, embryo pooling, and
Because
test her embryos. But
whatever
yes,
she has, that will be
I
also
agree. I
exhausted.
agree to Dr. Divya. There are so many patients who are just got married, and at least in Gurgaon, I think all of
Yes,
you will agree.
because
We have a
you
plethora
live. Yeah, they
of
are like there's a
who
certain
think
strata.
yes, and
They
so
don't even, they're not aware and they're into their 40s. They're just running after
absolutely.
some multinational, doing a night shift. Husband is
Yeah.
doing a day shift. There's a pool of such patients.
So they think they're going to be eternally young, no matter what you're going to tell them about their
Yeah,
biological
exactly.
clock for them.
They
So
just refuse to, like, mentally they are not aging. They are in like baby babu
So-
shona wale stage mein, and then suddenly
So
they
I
are into.
agree with initially also what I was discussing with, as Dr. Rakhi also mentioned, document it, what you want, let's
Yeah,
write it
you should,
down.
huh?
And
That
then
is
I
very
always
important.
write couple wishes to go for an IUI.
Yeah, even
You know?
I will put 2-3 arms, counsel for all options, this. But the couple is keen on this. I will definitely write that. And that is playing safe for myself. But you never know because these kind of couples, they can come back and say कि आपने ही नहीं बोला ये.
Yeah, basically we need to
So आप
explain
अपना
that IVF
Yeah.
cannot counter all the age-related effects. This thing that we are spending on IVF and
Yeah.
which can now compensate for all the ovarian aging,
Yeah,
age-related
Like,
effects on
sometimes,
fertility.
the patient also feel very rushed. It's your first consult, they're meeting you. They feel, oh, I've been pressurized into it or I was rushed for it. So it's very important they come for counseling. Exactly the tubal testing. They feel like they're very rushed towards. If they're feeling rushy, I would not like to push them. I like to take them little slowly and steadily. They make
we
their
have to
mind
go
and
slow with them.
yeah.
You always want to keep your pallada bhari and you'll say, boli thi, whatever you decide, okay?
Yes.
Dr. Divya, now would you like to try adjuvants, which all ma'am has spoken about so many?
Yes, she has literally covered everything. But my
Focus on-
favorite one is DHEA. DHEA, definitely I like to go with DHEA. Even I use because now these are the options we all know. So what I use, I go for DHEA. I go for antioxidant. And there's a combination of DHEA, CoQ10, melatonin. It's a brand like Ovaris. So I always give for maybe 4 weeks, or I will start as soon as they come to you, so that if there is, because we know these are not going to increase the AFC or increase the AMH. It's only the sensitivity to hormones or only the little part they play in folliculogenesis. So that is the benefit we will get out of them. So I start them whenever I start. If they're coming in the prior like cycle, then 4 weeks definitely yes. And I stop DHEA and all the moment the patient ovulates. I document the ovulation on my scan. I will stop from that day. So that is how I give.
Okay, so you don't continue
Definitely,
after
you have to
ovulation?
tell them off smoking and alcohol and whatever, like these are the things, whatever antioxidants, whatever things, their lifestyle which increases antioxidants, I'll tell them to stop. I also tell them to eat a lot of like broccoli and bell peppers and berries. So the natural form of antioxidant they get. So this is what as an adjuvant I give. And ecosprin also I use. So if, I
Right.
don't know whether we take it as an adjuvant or something else. But just to increase the blood supply to the ovaries and endometrium, ecosprin is a simple medicine and I've been using it since long.
You use testosterone gel or patch
Gel,
apart
I have used in few. Yeah. There's so many testosterone gel and patch and growth hormone. Dr. Asha Baxi ma'am, she has covered everything, so I'm not just repeating them.
Right. So when do you start gel? How many days
Gel
prior?
in the
How
prior
many days?
in the previous at least like day 21 I will give them for like 3 weeks, minimum for 3 weeks in the
Okay.
previous cycle.
Okay. And when do you stop this gel? On the day when you start stimulation?
Before no, I will like trigger till trigger I give.
Okay. How do you, Dr. Mino, how have you been using testosterone? How much and whether you use patch or gel? And when do you start? Dr. Mino is not there. So the DHEAs, testosterone, all these, they improve the follicular sensitivity,
Genesis, yeah.
the receptors to FSH and
Basically, insulin IGF-1, they are
one.
like,
Right,
they increase the concentration of IGF-1, which in
right.
turn helps in folliculogenesis. So that is the mechanism of action, proposed mechanism of action. However, ESHRE, like of all the RCTs and multicentric studies, they don't prove any benefit out of them. Because some
Right.
studies they say they are working, some studies they say they don't. So there's no conclusive study to say that we should use them. But still, these are the only tools with us. So we use it often. We end up using them often.
Yeah. So there have been studies which say that
Yeah.
pre-treatment with
Pros and cons,
DHEA
both.
may be associated with improved live birth rates. But what our ESHRE says that these are both conditional statements, and the use before stimulation is probably not recommended for responders, and even same for DHEA,
DHEA, yes.
or during stimulation is not recommended for poor responders. Now, this is the good practice recommendation on the add-on, which is very late 2023 in human reproduction, which say none of these adjuncts, metformin, growth hormone, testosterone, DHEA,
Testosterone.
indomethacin, sildenafil, before or during stimulation are not recommended. So we can use them, but what our
There's
good
no such
practice
recommendation to use them, right?
are not recommended. But we have been using it, and we also about growth hormone. Have you used, Dr. Divya? How much? When do you start?
No, I have not used growth hormone to be very
I
precise.
think I use it growth in poor responders, and I started with the stimulation only. 4 units of growth hormone. It has a synergy
Still,
to FSH on follicular development and also on IGF-1 as androgens. And though higher quality or number of oocytes retrieved is not what we have found, but definitely, I mean, it is another
good.
which can be used, which I think also is not the
And
good
when did you
practice.
stop? When did you stop? Like you
Uh,
started from the day of stimulation till the day of trigger.
it is costly. We give it for 2 weeks. I mean, till 10 days, 12 days. I mean, continuous.
Almost the day of trigger, right? Okay.
Yeah.
I think I've also got very good response with growth hormone, especially
Okay.
with recurrent IVF failures, poor responders. But yes, definitely it adds a cost to the cycle. So that's something that we have to counsel the patient. But yes, till the trigger is what we do. Day 2 we start and till the trigger.
Trigger
Right.
till the day of
Yeah.
trigger.
Yes, till the
And the coenzyme Q10 is something which we all love and which we all
Yeah,
give.
loved.
So,
We
so how,
fans.
yeah, so how do we give? Or how does it affect? Does it affect? And for how long we should give it?
It's for oxidative stress.
Okay. So it
Q
is
actually has been recommended as a mitochondrial activator, basically,
right,
and it
right.
decreases the apoptosis, and it is recommended for at least for 3 months before your stimulation cycle, which is a very long duration actually. Would a patient wait for 3 months, especially a poor ovarian reserve? So we actually tend to start it as soon as the patient visits us. And if the patient is willing to take it for that longer duration, it's fine. Otherwise, we just let it continue throughout the stimulation till the day of the trigger.
Right, exactly. So we can start the patient on
It's
CoQ
as
and
soon as
all
the
the
patient comes.
concoction,
Yes.
aspirin or whatever this folic acid and DHEAS, the day she walks into your consulting, and
OPD.
it can continue till the time we have started her induction and things like that. So CoQ10 is something which does improve, does supplementation. This was a review and meta-analysis of a RCT, and it did say that it may increase the birth rate, the pregnancy rate in
Pregnancy rate.
placebo in women without an effect on the live birth rate. So the role of antioxidants, all these antioxidants, CoQ, vitamin E, vitamin D also we should, if
Melatonin.
there are deficiencies, melatonin 3 mg per day, lycopenes, amino acids. So all these, the Cochrane, what it says is that there was low to very low quality evidence to show that taking an antioxidant may benefit these women. So antioxidant is not recommended actually by them. Now Dr. Preeti is not there, so we can just quickly go about this. The ovulation induction in these cases, what all would you use, and how many cycles, and how do you stimulate them? So this is, I think, for a patient who is not agreeing to go for IVF, I suppose. So we can give her clomiphene or letrozole or extended letrozole step up, where we increase the dosage 2.5, 5, 7.5, and 10, and also add FSH and HMG along with the follicular monitoring, and then trigger, though the chance of success is very less, and we do it
Less
only
than
for,
10%.
yes, up to 2 cycles only. Now, role of IUI and how many IUIs, it may be combined with ovulation induction in this subset to maximize the chance of conception without compromising on time, though success rate is around 15 to 20% per cycle, which should be explained, and it should be given only for 2 cycles only. Now, when should we refer these patients for IVF, and what is the, depending on her age, if she is more than 37, if her AMH is less, then one, if she has been married for more than 2 years, if ovulation induction IUI has been tried and it has failed, or if we have another factors, if there are abnormal semen factors or there's a unilateral tubal block, then in all these, when if there any of these factors are accompanying, then it should be a IVF that needs to be considered. Now, Dr. Shilpa, how do you stimulate them? These we are talking of Posidion group 3 and 4. How do you stimulate them? Whether you go for a natural cycle, which stimulation protocol, and what would be your choice of gonadotropins in these?
The Poseidon actually recommends the long GnRH agonist protocol, but what I clinically use is an antagonist protocol. I use HMG because I do need LH activity here, and I combine clomiphene citrate 100 mg with 300 units of HMG. And what I do at start is that I usually sit with my patients and I tell them that, see, we are going to start this. And after 5 days of stimulation, we are going to see how many follicles we are recruiting. Is it corresponding to the AFC antral follicle count that we are seeing or not? And then we take a decision of whether we are going forward or not. Also, we also at the start itself talk about a dual stimulation and a need for it if it is needed. Suppose if the retrievals are less than 3, oocytes, then we practically make them understand that dual stimulation is something that would be recommended for them.
Okay. So at what gonadotropin you use HMG, or you use recombinant FSH and then add HMG or recombinant LH?
See, you usually start with, we talk to the patient about the cost. If the cost is a limiting factor, then we start with HMG only and we continue with the HMG only. But if cost is not a limiting factor, then we may start with RFSH with a little activity of LH. We would add HMG 150 extra into it. So we will start with 150 of REC with 150 of HMG. And after 5 days of stimulation, we convert to HMG completely. That is how we proceed actually here.
Right. So now that is good. Actually, you're telling your practical what you do. That is what we all want to share each other way
It's
of.
recombinant LH, yeah.
Yeah.
So
how do
LH actually
ideally you can add
that
LH.
is required. I do agree to it, but it
It's
makes
very
the cycle
expensive.
cost very expensive.
Expensive, yes.
The city that we are in, we are not in a Gurgaon where we see a lot of patients who are willing to pay that much. We are in Dehradun, and here patients do look at cost a lot, and that is why you have to balance everything. Though yes, REC LH with the REC FSH is the best protocol to use for this patient group. But then sometimes you just can't use what is best just because of the place you are in.
Exactly. So, Dr. Lakshmi, what FSH dose would you give in these Posidion group 3 and 4? Because they
First of all, I completely agree with Dr. Shilpa that this is what we normally they say that recombinant FSH 300 or higher dose of, but then of course it is very costly to the patient, and then patient will not be able to afford so much of recombinant FSH. So in my practice also, I give the same way that I add recombinant FSH along with the HMG initially, and then convert it into the, but though I start with a higher dose. Sometimes even I start with 375 dose instead of 300. So especially if a patient is little obese or high BMI, then 300, like I never start with 225 in these patients.
Yes,
Which we used to do earlier, maybe before COVID.
300 or more than 300. So that is the usual protocol.
300 or 375.
Age, yeah.
Yes, but I differ with one thing that Dr. Shilpa was mentioning, that we go for pooling instead of dual stim. Dual stimulation, normally we don't prefer doing a dual stimulation. We go for pooling. Like dual stimulation in only those patients who are in hurry, who have to go abroad.
Or chemo or radio, like onco patients. Onco patients where
There are a limited time
very
for 1 to
less.
2 months. So pooling
Time
is
is
a
very
better
less.
idea, because my experience with dual stimulation is not as good, because I think pooling we get better number of oocytes. And also I always do a PRP in first pickup. During the first pickup, I always do a PRP, and before, like, if I always counsel the patient for pooling in such patients and do a PRP during the first pickup. So that
PRP, how do you do? After stimulation, you do ovarian PRP?
Yes, I do PRP after the pickup. Yeah, once I do the pickup, the same sitting, I do PRP, and then I stimulate in the next cycle, and then I have got good results with this PRP therapy.
Okay, so how much gap you take for the second cycle to, I mean, you
Second
do
day two of your periods. Yeah, 14 days. Yeah, I give a withdrawal of 10 to 12 days, and then she has a period, and then start from day two.
What Dr. Lakshmi is saying is also very true. I mean, when you do a PRP, and sometimes if patient would also require around 4 to 5 weeks, if you're trying to give a gap, say about a cycle, even that really helps, because PRP, when you look at the literature, they say that the ovarian response for the next cycle, whatever the RCT has happened, has been after 3 months to 6 months of the PRP. But yes, if you're not going to wait, that is 1 month gap is also like a 3 to 4 weeks gap, where you are again pumping them with antioxidants, CoQ, and this PRP, and taking them for embryo pooling. So that also really helps the patients.
How many cycle interval do you prefer, Dr. Meenu? I mean, like Dr.
See,
Lakshmi takes in next immediate cycle for her second.
I like to
One
take
to
a
two,
break
one
for
to
1
two.
to 2,
Yeah.
1 to 2
Usually I also
cycles.
take 1 cycle break just to give rest to the ovaries and to the patient also.
Yeah,
And
and for the PRP to work also, it really works very well if you take a gap between 1 to 2 months, because her egg reserve is not going to dip immediately. But what happens is that she also gets
yeah,
rejuvenated
1 month doesn't
and
make
the
much of
PRP.
difference.
Yeah, yeah. And for the
Right.
PRP to
So
work,
what about LH stimulation? LH stimulation is another important issue that we normally talk in these cases, because
L
well, does it really make a sense, or is there any difference in the live birth rate if we add recombinant LH? What are the studies? Anybody can comment?
see, there has been a meta-analysis which also has mentioned that the REC-LH, or the one study which said that REC-LH is actually increasing your oocyte quality as well as the pregnancy rate. But they did not mention the take-home baby rate. But when you look at the meta-analysis, said that the REC-LH or HMG, there was no significant difference in the take-home baby rate. So again, REC-LH, whenever you look at, there are times, even for Gurgaon, I would say, it's not so easy to convince a patient because these are poor responders and we are going for multiple cycles. So the cost is so much, the financial burden is so much on the patient that even we are thinking twice. But in my practice, what I felt that has been a difference is HMG, a good HMG with a growth hormone. If I want to add the cost, I would rather add a growth hormone to her cycle than a REC-LH, because it's not increasing my the take home baby rate. So this is the way I would like to go forward.
Doctor, I will take opinion of all three, four of my panelists. Dr. Divya, do you use recombinant LH or you use HMG?
No, I use HMG. I don't use
Okay. Dr.
recombinant LH.
Taki, what do you use?
I also use HMG. We don't get that strata of patients that they will pay for a recombinant LH.
So Dr. Shilpa already is using HMG along with REC FSH. And Dr. Lakshmi, what about you? Have you been using recommended?
Mostly I'm using HMG with REC FSH.
Okay, so
I just want to add my little inference that for some of my patients, even well-to-do and international patients, there has been a newer drug where we are using REC FSH and LH combination has come from Merck. So that also I have used, but I did not see a significant difference as it was portrayed, that, you know, it will make so much of a difference to your cycle, number of M2s, or the quality of the embryos. But yes, it jumped the cost of the cycle too much for my patients. So that became very tricky for me to adjust for the next cycles, and they were not ready for an embryo pooling cycle. So that really didn't serve us so much.
So, Dr. Rakhi, what trigger now? Dual trigger, double trigger? What exactly you explain? What is dual and what is double trigger? And do you use dual and double trigger in these cases? Because anyhow, HCG and agonist we all know.
So basically, dual trigger is when we are giving both an agonist, GnRH agonist, and a low dose of HCG, which are given together at the same time, and the OPU is scheduled 34 to 36 hours after the trigger. And double trigger is we give the agonist earlier, 40 hours from the OPU time, and then HCG is given 34 hours before the OPU. The benefit of using a dual trigger is that they say GnRH agonist leads to FSH rise also, and it is more physiological. Along with that, HCG supplements this. Initially, it had come out in cases of suppose a suboptimal retrieval was there, or unexpected poor response, or a empty follicle syndrome. So next time we used to give a double trigger. But there have been various studies in case of normal responders and poor responders also. The studies have been conflicting whether this dual trigger, it increases the number of oocytes, number of mature oocytes, and the pregnancy rates. Because earlier they were observational studies and then RCTs were there. So I think in the last, there was a meta-analysis in 2022. They concluded that in normal responders, it increases the number of oocytes, the number of embryos, and the pregnancy rates. But in poor responders, it might increase. They said it might increase the number of only the M2 oocytes and the pregnancy rates. But there is no harm in giving a dual trigger. It's not increasing the cause too much. So instead of a simple HCG trigger, we can give a dual trigger in these patients.
Right.
So I generally prefer giving a dual trigger in my patients.
Wonderful. So, Dr. Divya, what is this duo stim? Just explain that. So, and then I think
We have just discussed it. That is like we stimulate twice in a single cycle. So that is like a follicular phase stimulation and a luteal phase stimulation. So it is basically based on the theory that the follicles are being recruited throughout the cycle. It's not that there's just one wave of follicles which are being recruited in the early follicular phase and we can retrieve just our follicles from that early follicular phase stimulation. So it is done mostly in like where we have very less of time, like in poor responders also we can do that. But more use where the patients are for chemotherapy or radiotherapy and we want to extract maximum follicles in one cycle. So that is like estrogen priming and then stimulation and then adding an antagonist and stimulation. What the books they recommend, again, recombinant FSH and LH, which we have already discussed, that the recombinant LH part can be very well taken care of from a from the like the one we are using, like from the menopause, like the urinary, like FSH and LH combination. So that is what, that is how we do it. And then like one retrieval is taken after is done after like almost 10 to 11 days of stimulation. Then you give a trigger. After 36 hours, you just retrieve all those follicles. And then there is a gap of 4 to 5 days. And then you can immediately start the next stimulation. So that way, in a span of like 28 to 30 days, you can get 2 oocyte retrieval and you can pool all those oocytes for later use. So this is how this is done.
Basically, it is only for patients who are undergoing fertility preservation.
Yes, for more for those patients for fertility preservation.
So, what are any other newer options for ovarian rejuvenation? I think we've already touched upon this use of PRP.
Yeah, PRP and stem cells. Stem cells are there.
Yeah. So, have you been using, anybody has their practical experience can add on the role on ovarian rejuvenation? How do they do it? And what is their practically, what was their experience? Whether there was an increase of oocyte number and the oocyte quality and the embryos that they could make was much more than before. So any practical experiences, and all of you can just add on to that, and then we stop on this. Anybody?
I have done once, but it doesn't make much of difference. I have done ovarian rejuvenation that was done laparoscopically with the help of that ovum pickup needle only I did, and but it didn't make much of difference to the
Dr.
patient.
Lakshmi, I think you have used it. I'm sure. Dr.
Yes,
Lakshmi.
so I took a patient, she was 40 years for a laparoscopy and did her PRP. And after I think 2 to 3 months, she conceived naturally. So this was just one patient, and but there are many patients in whom I do viral ovum pickup. I'll take out the oocytes, retrieve out the oocytes, and do the PRP. In one such patient, she had an AMH of 0.9. She was a known case of endometriosis. She was 32. And in the first cycle, we just got one oocyte, which was very bad in quality, very bad oocyte. And then in the second cycle, immediate cycle, then we got 2 good embryos. She went for another cycle. She said, "Ki ma'am, I want to go for pooling." So we froze those. We froze those embryos, and then again PRP in the second cycle, and then again we did a pickup and got 2 embryos transferred in the fresh cycle, and she conceived. So we have her 2 embryos left, which are frozen in the second cycle, and she conceived with the third cycle. So this way I found the PRP results very good, especially in that particular patient.
I also had a patient who was a doctor, and her AMH was 0.01. She was young, she was 31. After completing her post-graduation, she came to me and she had just undergone a few ovulation induction cycles. Her husband was not agreeing for a donor egg IVF at all. We cancelled her stimulation 3 times. I did ovarian PRP 3 times, explaining it might work, it might not work. And after that, she took a break for a few months and later on told me that she has conceived spontaneously. But data is too few to say whether it works or not.
So I just wanted to share one thing that yes, it does. I feel we should document this because all of us have few studies that we have done and few cases, or could be a case reports. But even for me, I think the very first time that I did an intra-ovarian PRP was for a doctor only who had come to me saying, and that was way back in I think pre-COVID time, somewhere around 2017 or 2018, where she said, let's try this, ma'am, I don't want. And she was a failed stimulation that the pickup could not happen. So and she said, why don't, and she was referred for a donor egg cycle. So we said, okay, let's try. This is important that in such patients where they don't want to go for a donor egg option, this is something which can be done. It's not something like a stem cell that we cannot do routinely in our OPD. And yes, activation is not allowed by ICMR, earlier also the ICMR guideline. So all we can do is simple PRP, which can be done. It doesn't require anything else. And yes, I routinely do if I'm doing an embryo pooling cycle, then I like to do it like this, that after the retrieval, like as Dr. Lakshmi was discussing, that PRP can be done, wait for another 2 months while she's recovering and do an embryo pooling cycle. So even in that particular patient, we did 2 pickups and we had 3 embryos were made, but the quality of embryo in the second cycle was better than the first cycle. So whether it was because of PRP or we gave a break and other antioxidants, that yet to be said. But yes, we did get, and at the end of the day, we got a baby home. So I think for such patients, this definitely has a place and a role in our clinical settings.
Yeah. So, Dr. Shilpa, have you, I think you find any comments from you? Otherwise, we call it a day.
We did try PRP in a couple of patients, but actually we never saw any response. I mean, I didn't get any good response, so I have stopped using PRP now. So I am not a proponent or a supporter of PRP, to be honest. So that is why I like to not comment,
Right.
because I have not seen any good response.
Yeah, it is experimental. But people who are happy with it are super happy with it.
Correct.
Because we also heard Dr. Naina Patel. Dr. Naina Patel's talk we had, I think, 2 months back on the same platform, and about the ovarian rejuvenation that she spoke, and about even the thin endometrium and the way stem cells that she has been using, and even putting into the uterine vessels, those micro
Spiral arterioles
into the spiral arterioles in the thin endometrium. So it has been, she has a good number of cases, and she has shown that the results are there, and the patients have conceived even with thin endometrium and POR patients. So we have to, I think, though it is experimental, it may have a role. Thank you so much, my expert, Dr. Meenu, Dr. Divya, Dr. Rakhi, Dr. Lakshmi, Dr. Shilpa, and all of them, all of those who have joined us today and who have been with us on this platform today. I think it was wonderful to have you all here, and wish you all a very, very happy new year once again. And again, we would continue with our this once a month webinar along with our this discussion for the Fertility Sterility Journal also once a month. So we again meet at the end of this month on the fourth Wednesday of this month. Second and fourth Wednesdays we will be meeting. So thank you, everybody. Thank you, Jagsonpal. And over to Dr. Deepika for the summing for your.
Thank you, ma'am. And thank you all the attendees and all the faculty for joining us today. The session today was brought to you by, oops, my slides are not working. The session today was brought to you by Cystelia M, MEMUP, Lycored M, NAARI division of Jagsonpal, and also My Sakhi, the CSR initiative of Jagsonpal. For more updates, you can scan the QR code to reach the website www.mysakhi.in. With this initiative, Jagsonpal is involved in spreading public awareness about women's health and wellness from all life stages, from adolescence to menopause. Besides this, the company has already made a positive impact by building sanitation facilities in Punjab, Haryana, and Uttarakhand in government girls' schools while promoting women's health and hygiene. With My Sakhi, we invite you to join us in our pursuit to spread awareness and promote better management of women's health. Thank you very much. And we continue to do our 2 webinars that we have been doing monthly with ISAR Haryana chapter. Thank you.
Yeah. And we had, I think, I just read a comment from Dr. Sanu Delhi. He is from Kathmandu. So thank you so much. Welcome, Dr. Sanu. I'm not pronouncing your name.
Ma'am, it is Dr. Sanu Dali. She has been a very regular attendee in Jagsonpal, webinars. She's a very senior doctor from Kathmandu.
Thank you so much, Dr. Sanu, for being there with us, and hope to see you in NISOG International Conference March. So it is in, I think, Nepal conference that you're talking of. Please share the brochure. We can put it on.
Yes.
Yeah, she's there. Can we have her for a minute? She has raised her hand.
Yeah,
Dr. Sanu, you can join. You can please.
She can speak now.
Unmute yourself and just say hi to our Indian friends.
Hello, all of you. I have unmuted.
Okay, no, you are unmuted now.
Yeah.
Can we have the video?
No.
No, ma'am, video is not possible here because I have to first promote her. Let me promote her.
Okay.
Okay, I'll promote her if, she's joining in the faculty side, so now she'll be able to put her video on if she's okay with it.
Yeah. Oh, wonderful to have you and wonderful to see you, Dr. Sanu. Please unmute yourself now.
Yeah, I've unmuted.
Yeah. It is so nice, Doti, because I have heard your session so many times during COVID time also. And you had one infertility with a Nepalese candidate.
Yes, we had with you. And now this time, I think I will share every time the link with you because I think I'd lost contact with you. So
yeah, that's right. Yeah. Now, because then I went to US for a year. That's why I lost the contact. And I will be very happy to welcome you all in Kathmandu.
Sure. Ma'am, next time when we have our next webinar, I'll share the link and Dr. Deepika would do that for you.
Okay, fine. Thank you.
More friends from Nepal joining us on this platform.
Okay, thank you so much. I am very, very senior. Last 5 decades I have been practicing. 1979, before you were all born.
Thank you so much. We are blessed to have you, and we would love to have you in our future webinars as well.
It's a great pleasure to learn so many things from you all. Thank you so much.
Thank you, everybody.
Bye.
Thank you so much.
Thank you.
Bye-bye.
Bye. Bye. Good night. Good night.